Assalamu alaikum. Endovascular aneurysm repair, our experience. This is the working place, Ibn Sina Medical College Hospital, as well as the Ibn Sina Hospital, Dhanmondi. This is our team member of Ibn Sina Vascular Care Center. So, EVAR in Bangladesh, journey started on 2008 in United Hospital, Dhaka, under leadership of renowned cardiologist Dr. A.N. Momin Jamal. This is the first EVAR case in the country. So aneurysm permanent focal dilatation, that is more than 50% increase in compression to normal native artery. Types of aneurysm, one is the true, another is the false aneurysm. This is a picture of saccular and fusiform aneurysm, and the right side we can see there is a false or pseudo aneurysm. There is a hole in the artery, and leakage of blood from native artery to the containing the surrounding tissue. This is fusiform aneurysm, and this is saccular aneurysm. One is concentric and another is eccentric. And the eccentric aneurysm is dangerous as it is more prone to rupture. Abdominal aortic aneurysm, when the diameter is more than 3 cm or diameter more than 50% larger than proximal segment. Rupture risk, as we know, as the diameter of the aorta increases, chance of rupture also increases. When the diameter is more than 7 cm, the rupture risk is more than 30. Abdominal aortic incidence 5% more than in more than 60 years of age. Male is to female 2:1, white is to black 2 to 3:1. This is a picture of pulsatile abdominal lump. So the investigations, that is ultrasound, X-ray, and CT MR angiogram as well as catheter angiogram are needed for diagnosis and treatment of abdominal aortic aneurysm. Ultrasound of the whole abdomen shows the dilated abdominal aorta. CT angiogram, we can see there is a infrarenal abdominal aortic aneurysm. This is another picture of lateral view. This is conventional angiogram, and this picture is taken during EVAR procedure. So management in case of asymptomatic patient, avoidance of smoking and control of hypertension. But question of intervention arises when diameter is more than 5.5 cm, though the patient is asymptomatic, expansion rate more than 1 cm per year, and if the aneurysm becomes symptomatic. And two management principle, one is the open procedure, another is the endovascular aneurysm repair. So open procedure indication, the asymptomatic patients having this diameter more than 5.5 cm men, and in case of women more than 5 cm. Growth rate more than 1 cm per year, symptomatic. When there is hostile aortic neck, this is indication for open procedure. Short angulated neck more than 60 degree, trapezoid neck calcification, high burden of thrombus. So this is indication for endovascular aneurysm repair, asymptomatic patient, and these are the following dias and expansion rate. Contraindication, when there is hostile aortic neck, it is not possible to deploy the endograft there. This is diagram after making the CT angiogram with the help of the 3 Mencio, this is a apps, the different lengths and diameters of the endograft are measured. This is the picture how the endograft is deployed in aortic aneurysm patient. This is animation. We can see there is two parts. One is the main body, another is the iliac limb. The deployment of the main body through the right femoral artery. And the right femoral artery, there is two technique. One is the cut down and another is the percutaneous technique. We can see the deployment of the main body of the endograft. There is hook which is deployed just suprarenal. This is deployment of the main body along with the right iliac, and last of all, deployment of left iliac limb on the contralateral side. We can see the deployment of the left iliac now. So this is about animation. So complication after EVAR, device specific hook fracture, modular component separation, migration, and there is also endoleak and endotension. This is types of endoleaks. This is different from open vascular procedure. There is type 1 endoleak, that is the endoleak from the proximal entry side, proximal side as well as the distal side. If there is such sort of complication during the procedure, it should be corrected at that time, otherwise the procedure will fail. And type 2, this is the retrograde flow from lumbar artery or inferior mesenteric artery. And type 3, this is due to modular separation. And type 4, this is due to failure of the fabrics. We can see this is a live case, this aortogram, we can see this is infrarenal aortic aneurysm. And the second picture shows patent iliac artery. Patent iliac artery, the right iliac artery is patent, and the right one shows delivery of the bifurcated main body. Delivery of the bifurcated main body is continuing. We can see on the right side still this is a self-expanding system. So gradually we are deploying the endograft just distal to the renal artery. So release of contragate as well as release of right iliac limb. Last of all, deployment of the left iliac stent from the left side. And the right one shows stent graftogram. There is no leg and we can't see the aortic aneurysm sac now. Picture of the whole stent graft, and last of all balloon dilatation by non-compliant balloon. And at the end of the completion aortogram, there is no leak. So this is last. So EVAR different patterns. Another is fenestrated endograft and aorto-uni-iliac device. Fenestrated endograft for pararenal aortic aneurysm. This is a picture. This is a complicated case where aneurysm involves the renal artery as well as it can involve the SMA celiac trunk. This is CT angiogram of the pararenal aortic aneurysm. So fenestrated endograft, single or multiple fenestrations are made in the endograft before procedure according to origin of native renal, superior mesenteric or celiac trunk. This is a case done in NICBD with the help of Dr. Girish. He is a renowned radiologist from Mumbai. On-table fenestration of endograft by flexible end of on-4 coronary wire was done. Common femoral artery exposure, and this is deployment of the main body of the aortic endograft in case of pararenal aortic aneurysm, and deployment of the main body of aortic endograft continuing. Cannulation of the renal arteries by percutaneous brachial approach, we can see. Cannulation of renal brachial approach, cannulation of left renal artery and SMA by percutaneous brachial approach also. Another picture of saccular aneurysm where aorto-uni-iliac endograft is used. After deployment of the aorto-iliac endograft, fem-fem crossover bypass by PTP graft should be done. This is catheter angiogram showing saccular aneurysm, and deployment of aorto-uni-iliac endograft was done. Computational angiogram showing exclusion of the sac. In operation theatre, patient taken from cath lab to OT and cross of fem-fem bypass was done. So aortic aneurysm scenario in Bangladesh, some remarks. No specific data. Mostly detected during ultrasonogram of abdomen or X-ray chest. Good number of cases are pararenal aortic aneurysm, needs fenestrated endogram. This is high-tech procedure, also costly.
Okay.